All right, well, good morning, and thank you for being here. I want to appreciate the invitation to present you today. My name is Dr. Moshiri. I practice in St. Louis, Missouri, along with my father and sister, and it's an honor to be here to discuss our topic. I do want to claim a disclosure. I am a paid consultant for Align Technology, the makers of Invisalign, and I'm also a co-owner, co-founder of the Aligner Intensive Fellowship, which is a clear aligner education course. What are we going to review today? So a couple things here. For one, we're going to go over some important considerations when setting up your clear aligner cases so we can hopefully decrease refinements and have more predictable case outcomes. But as we all know, when you treat with clear aligners, you may run into some issues. So when you run into those issues, we want to review how to identify them and address them. To understand the concept of active retention, which is a tool we use to help finish our cases, and also to go through the use of elastics to finish your cases as well. So Dr. Nanda was here previously going through a lot of studies regarding clear aligner efficacy, and it seems like a lot of the studies tend to hinge around 50% in terms of the summary of the movements. And some of us take that to pit aligners versus fixed appliances, and I don't think that's really fair or accurate, meaning we don't say braces are 50% accurate, but when we put braces on teeth, it doesn't always turn out so well, does it? And why is that? It's because we take our fixed appliances and we modify them. You may alter your bracket positions, for example, by flipping them upside down. You may tilt them off the long axis. If you're trying to do a gable bend into extraction sites, you may put them into a rotation more. You may exaggerate the curve of spee in your arch wire to deliver the proper force system. You may add torquing springs to get better torque in your appliances, et cetera, right? We customize things for our patients. So, in my opinion, with the current literature on clear aligners, we can't have a reasonable discussion of efficacy until that literature actually reflects what a seasoned practitioner does in their office to set that case up to get the outcome they want for their patient. Does that mean the literature is inappropriate? No. It's a good guiding point for us to make inferences off of. But it's not appropriate to say aligners don't work. Now, having said that, when we use clear aligners to treat patients, things don't always go well. And why is that the case? Number one, I think a lack of resolution of the curve of spee is a big reason for that. Aligners aren't very stiff, and so it is challenging to level curves of spee in the absence of crowding especially. Overdevelopment of the maxillary arch is another big one, I think. When you're expanding an arch form digitally, you don't have necessarily bone to look at. Now we have CBCT integrations to make more educated decisions, but at times you have inappropriate movements happening where you have consequences that are unintended. Also, because of movements not expressing 100%, you may get a lack of arch coordination, which can lead to interferences and bite opening posteriorly. And of course, there are other etiologies as well, so I can't, for lack of time, go through all of them, but these are probably the three main ones I think give us issues. So having said that, the first one, let's kind of go through these topics. Lack of resolution of the curve of spee. In my opinion, humbly, I think no matter what type of plastic you're going to treat with, at some point you have to incorporate some level of overcorrection of certain movements, just like we do with braces. We do that with braces, right? You still wipe a reverse curve of spee in your stainless steel arch wire, right? So you have to always incorporate or think about doing that when you're designing your force system. And when you have bite opening, for example, it needs to be exaggerated. You always have to exaggerate cases that present with a deep bite to get the outcome you want clinically. And this is a patient that we just kind of went through doing some restorative on bite opening, and that's her case finished on the right-hand side. So when you have your first clin check, my goal always is to address the vertical dimension. It is extremely important that you focus leveling the curve of spee in your first clin check, because if you don't do that, you have just bought yourself multiple refinements on that case. And my goal is to only have one refinement with attachments on for a patient and to then go to finishing that case. That's my goal for the majority of my patients, and we achieve that for over 90% of our patients in our practice. So your first focus, again, should be on leveling the curve of spee. It's extremely important. And this is what we're trying to avoid. We don't want heavy anterior contacts. We don't want a posterior open bite. So why would this happen to us? First, I believe inadequate attachment design and not prioritizing anchorage. If you're intruding incisors, there's a reciprocal extrusive force in the posterior. The aligner wants to lift off the teeth. How can a aligner stay on posterior teeth without attachments? It's physically impossible. You have to have attachments on the posterior teeth at minimum. I personally like to put them 2 to 6 bilaterally. Imagine trying to level a curvous spine and fixed appliances with no brackets 4 to 6. Not going to happen, right? You can maybe use an intrusion arch, you can use segmented mechanics, that's a different story. But with continuous mechanics, you cannot do it, and aligners are continuous mechanics. Lack of over-engineering of movements to account for lack of material property strength. We are basically treating with a nitile wire for the duration of treatment. And so we have to take that into account, and we have to go ahead and increase some of the movements or exaggerate them virtually to get the movement we want clinically. Not taking into account the side effects of certain movements. With regards to deep bites, if you have a deep bite with spacing that comes in your practice and you have to close the spacing, that bite is going to deepen clinically. Bites deepen when teeth move lingually. And so we have to overtreat those cases more than we would an average case that presented with crowding per se. So again, thinking about those things and overcorrect even further to get the movement we want. Another one is not diagnosing or taking into account Bolton issues. I think a lot of patients in our practice have mandibular excess Boltons or maxillary deficiency because of small laterals. And we can cheat Boltons with fixed appliances very easily. Because if you see it being an issue clinically, you can be reactive. You can step up your upper 2 to 2, step down your lower 2 to 2, open space behind the incisors, et cetera, et cetera. But when you have an aligner, that's hard to do. So you have to be more cognizant of that. Because our bites tend to finish deeper with aligners, so the Bolton will present itself more clinically than it would with fixed appliances. So again, being cognizant of that. Cases that have proclination, for example, so if I do have a Bolton, I try to maybe opt into restorative more often, let's say, if I want to do aligners. It makes it easier on me and sometimes a better aesthetic result for the patient. So just thinking through that. So for example, just showing you biomechanical considerations. If this patient comes into my practice and she says, I don't like my deep bite and I want you to open it, but I don't want any restorative done, I may start thinking about hybrid treatment to make this more predictable. But this patient actually wants restorative. And so that means a lot of her bite opening mechanics will be via proclination, because when you have attrition at the incisal edge, you also lose space interproximally. So to restore proper dimensions, I have to open space mesiodistally, which means we're going to procline this case open, which is appropriate for this patient given her initial incisal inclinations and her biotype that she presents with clinically very thick, so we can afford to procline her. So we're going to use clear aligners to open her deep overbite, combining intrusion with proclination, because we know that's going to be predictable. We're going to significantly exaggerate the amount of bite opening clinically. We're also going to upright her curva Wilson, but when we upright the curva Wilson, we're going to force heavy occlusal contacts, because normally your technician may even intrude the posterior teeth to have light contact when leveling the curva Wilson. You don't want to lose the benefit of doing that. That's an unsung hero to open a deep bite in a narrow case. So let that curva Wilson upright, but force heavy posterior occlusion to prop the bite open. And then we're going to use retainers with bite turbos when we're done. So if I'm going to use a golf analogy, we're going to break out that driver. Remember, the first goal of that clinch check is to really open the bite. And then that's the same patient in refinement. You can see it's not as open as what was predicted, even though we had proclination. So even though we had a more predictable form of bite opening, we fell short. But now that we're here, now I can go ahead and fine tune in a refinement to detail and then finish the case up. So again, this is this patient's first iteration of her clinch check, showing the bite opening. And again, showing exaggeration. How much do you open? I'm saying this jokingly, but until you get uncomfortable looking at the clinch check is probably when you should stop the bite opening in significant deep bite cases, right? And then that's the patient in refinement finishing up. I'd much rather be in a situation where, let's say the patient had 70 aligners and they came into the practice at stage 50 and I said, this is good, now I'm going to go to refinement. Rather than getting to 50 and we didn't get enough, and now I have to go to refinement to still focus on opening the vertical. That's a situation you don't want to be in. So the patient's ready for restorative, gets her restorative done, and this is a great really tool to offer adult patients that have restorative needs. Can we do this with fixed appliances? Yes. Do I want to be a 55-year-old patient with fixed appliances having this done? Probably not. If there's a better way to do it or an equal way to do it, then I think we have a responsibility to offer that to our patients. So how much do you exaggerate and why? It depends. Again, this digital treatment plan is a representation of a force system, not an outcome. So we want to make sure that we take into account the type of movement, because that will make a difference, and I'm going to elaborate on this specifically in the next coming slides. Staging of movement, as we procline teeth, bite opening is more predictable. If we're going lingually, we have to overtreat more. You have to add in more. Is growth remaining? This is a paper that I was a part of showing that teenage patients had more predictable incisor intrusion, which makes sense. Obviously, there's condylar growth, compensatory eruption, but still something to consider, obviously. Again, crowding versus space closure, and premolars. If I have an adult patient that had premolars extracted previously, that had relapse and a deep bite, those are really tough cases to treat with aligners, to be quite frank. And so you have to really overcorrect more or consider hybrid treatment potentially in those patients. And of course, from a biologic standpoint, is the patient brachycephalic, dolichocephalic, because that affects their musculature, their bone density, and those things are of course going to affect how your teeth are moving. So in summary, for some of these leveling of the curve of speed patients, again, I believe posterior retention is key. Make sure to maximize your anchorage. You can use, again, retentive attachments posteriorly to do that. I also like them on the 3s and 2s as mentioned. Staging, proclination makes the movement more predictable. If teeth are moving lingually, less predictable. So choose your mechanics carefully with that. And virtual overcorrection, extremely important in my opinion, that you need to really finish all your deep bite cases with 0 central contact 3 to 3. The amount of overcorrection you do depends on the variables that are on the slide. And what we know to be as orthodontists, that's how we tinker and customize all of our appliances, right? It's based on our experience. Conceptual overtreatment doesn't just apply to anterior intrusion, by the way. It applies to many different types of movements that we use with clear aligners. And so personally, I love to use clear aligners for open bite cases. And when we set up our cases, I don't sit there and say, well, aligners can intrude posterior teeth because that's what the literature says. I think aligners can intrude posterior teeth. And I set my cases up a little bit differently to facilitate that. And so how do we go about doing those things? Well, it's just understanding what we're dealing with. The clear aligner is a digital treatment plan that helps me to have diagnostic tools, but also it helps me to design force systems for our patients. And so when I learn, and I attend these AO meetings, I see the amazing lectures here and the biomechanics and the way they can treat malocclusions. I just try to customize and take some of those pearls and put it into this treatment plan using the software to do that. And so this patient, we had posterior bite blocks built into her clear aligner plan and anterior elastics that were worn from the lingual of upper 3 to lower 4-5. And by forcing the patient to bite down and the increased presence of the plastic, you can see very clearly that we got very profound molar intrusion and no TADs were harmed in this process. Now, can you use TADs with your aligners? I use them all the time. Sandra's going to give an amazing lecture showing you that next after me. But the more I've kind of just tinkered and dealt with things, the more I'm just kind of amazed that sometimes I don't actually need TADs when I thought I did. And other times, clearly, I will use TADs. But that's just the evolving evolution of being a practitioner. You're going to change the way you practice over time. This is a slide from Dr. Martin Coburn I borrowed, kind of a summary of the research out there, showing very predictable movements to not so predictable movements. And this slide is nuanced clearly because it depends on the type of study, depends on if they measured the movement after refinement. There's probably no overcorrection measured in any of these studies. Attachment designs are different, materials used are different. So how reliable is it? Again, it's a guess at certain movements here, right? But do I just discount and say, no, it's not good research? Absolutely not. You use this, again, as a guide for you to make informed decisions. So when we sit there and we go through and we customize and set up our ClinCheck, I look at movements such as tipping. Is overcorrection recommended? Not so much because it's probably a pretty predictable movement. And then we kind of go through other considerations as well. Intrusion, I may consider increasing it by 50% to 100%. Extrusion, I tend to not really exaggerate that movement anteriorly at all, but I may exaggerate it posteriorly if I'm wiping in a reverse curvus spee. So again, you want to come up with your own conclusions, I think, based on your clinical experience and maybe looking at the research as well. But we have to, I think, dial in certain overcorrections virtually for our patients. Rotations, you may want to do 5 degrees extra. If it's a 15-degree rotation, you may need some adjuncts. Root movement, 5 to 10 degrees extra based on what you're doing for the patient. Torque, I tend to double the amount of torque I think I need. So if I need 10 degrees of torque based on the Ceph, I'm asking for 20 because I find that it truly does fall short. So again, it's not appropriate to just say it didn't work. We have to take into account the inadequacies and customize for them. Expansion is a tricky one because there's obviously the bone you have to deal with, right? And expansion actually gets less predictable towards the terminal molar. So we have to understand that. Just like our wires, it's less predictable at the 7s to get expansion with the arch wire. It's the same with an aligner. So it depends on where you're treating at in the arch. What's the initial inclination of those teeth in terms of how predictable it is? Where's the cortical bone? So we just can't depend on what's happening virtually to make that understanding. So let's talk about expansion. With regards to overdevelopment here, this is a patient that is pointing to her joints. She's in pain. We're going to treat her with a splint first in physical therapy and just make sure that we can help her before recommending any orthodontic treatment with her joint pain. Patient post-splint therapy, she's posturing anteriorly. The splint we use is not a positional splint by any means. And we can see that she's posturing to get back onto her disc, but now she has to be treated in this position to maintain the asymptomatic posture. Had previous braces, headgear, 5 years of treatment, did not want to go through any type of orthodontics again. We even offered surgery to her, did not want that as well. So we're going to do our best to treat her with clear aligners to get her into a normal occlusal relationship. We're going to develop her narrow arch forms to accommodate that more anterior posture of the mandible, use attachments that level the curvus spee, and use retainers when we're done, of course. So this is showing just the force system we set up to intrude the molars to help hinge that jaw forward into the class 1 position. And you can see her arch form is developing quite a bit because the mandible is coming forward with this type of movement. But when we look at the case, we see that we leveled the curvus spee decently well. We still have more to go, but there's a nice posterior open bite. And why is that? Well, look at the palatal cusp. From here to here, it's dipping down, right? And so what ended up happening is this patient was expanded too much. You can see the teeth are in buccal version to begin with, so they're already leaning to the buccal, so I had no business developing the arch on this case, and the teeth are only going to tip, right? So I just didn't see that. I was so focused on leveling the lower, I missed the upper. And so what do we need to do? We have to unfortunately sacrifice the buccal overjet, get the case come back together again. It's a skeletal problem, didn't want surgery, so we're going to do the best we can, and that's where the patient ends up then finishing. This patient had a 7-year retention. She came in, she's holding stable with no issues with her TMD. If we do want buccal root torque, you need an attachment at minimum on the buccal. You can add one on the lingual if you want to throw the kitchen sink at it, but the palatal cusp should be sufficient enough to push up on. But the goal is to get twist. And again, think about the consequences if that root's moving. Where is the bone, and is that movement really even feasible for you to have happen predictably, clinically? Last thing to deal with is, as a major topic is arch coordination in terms of finishing issues. And so patient comes in that is mainly concerned about a lower crowding teenage patient. So seemingly a fairly straightforward case, lower anterior crowding, so the bite opening should be fairly predictable to happen. She does have stress tissue though on the cuspids, so we want to be cognizant not to flare those lower canines out while addressing the crowding for her. And so what we're going to do for her in terms of our treatment is to use clear aligners with IPR to limit the amount of flaring we're getting, yet open up the deep overbite for her, overcorrect our anterior intrusion to take into account the IPR that was added. Because when you add IPR, it may actually deepen your bite beyond what you want clinically. So whenever I add IPR, I tend to overtreat the bite opening a little bit more. Class 2 elastics for arch coordination and retainers for retention. And so here we see that we have our bite opening, IPR, and that we're finishing with 0 center contacts 3 to 3, or excuse me, 2 to 2. The 3s I should have done a little bit more, and you'll see why. And you see there's a bite jump at the end for arch coordination. So again, this is the first iteration of what happened for her. We get to the end of these aligners. This is just a different view of this here, showing the arch coordination. So bite opening again, and bite jump, which is a simulation of elastics for the patient. And that's her at refinement. So making decent progress, but what I always like to do is to look at the centric contacts on the refinement scan. And if you look here, things aren't really matching up so well, right? And so we have some interferences here on the upper left canine, probably because I didn't intrude the lower canines enough. It was just the 2 to 2. And we have some arch coordination issues that things aren't cus fossa. Why would that happen? Well, the patient had a little bit of arch development. As I mentioned to you, in the posterior, it's not as predictable as it is at the 4, 5, and 3 area. So there's probably a mismatch of the movements I wanted there. But is that a failure of things? No, I have to recognize them, I have to address them. So what we're going to do here when we have refinements is I'm going to initially assess all the initial contacts and try to understand why are there interferences there, if there are any. Is it from a lack of curvus speed leveling? Was it too much arch development? Was it a lack of arch coordination? And then imagine what it takes to remove those interferences. So again, what is the interference? Why did it occur? And chase that interference. Make sure you focus on what happened there. If you need to remove any attachments, you're welcome to do that. Sometimes we have to change and re-energize the force system to get the remaining movements done. And then evaluate the new ClinCheck to make sure that you've dialed in any further over-treatments, new attachment designs, and so forth to get the movement you need. And always still think about rubber bands. Rubber bands are an important part of finishing, not only with regards to midline changes, AP changes, but also with regards to finishing, which is what we'll talk about next. So this patient, I'm constricting the lower arch a little bit to help address the interferences, because I know that's a little bit more predictable in the posterior than trying to expand the upper, so I can finish strong and hopefully not have another refinement for this patient. Another view of what we're trying to do for her there with regards to the finishing from the buccal segment. And then we go into active retention. What's active retention? If you look at me go through this, you're probably not going to see very much happen at all very quickly with this treatment plan, and it's because we're just fine-tuning. But clearly in a clear aligner, you can't really have too much settling like a Holly. So when we get to the phase of where we want to do fine-tuning movements, I'll use an aligner with 0 attachments and settle the occlusion more for heavier posterior contacts and do any fine-tuning for the patient, but all attachments are gone. But this counts towards their 6 months of retention. We ask for 6 months full-time retainer wear, then to bed lifetime. The patient is ecstatic. Why? Because attachments are off. But the patient was told in the beginning of treatment they will need 6 months of retainer wear. So I got through one stage of refinement with attachments on, and then I go into active retention. That keeps our treatment time for most patients around 1.5 years, but allows us to still tinker and fine-tune things as needed and to settle the posterior occlusion just like we would expect in a Holly to happen for patients. So that's the patient all said and done. Pre- and post-treatment records for her. So again, with finishing with braces, we will reposition brackets, we bend arch wires, we section wires around elastics, we robotically bend arch wires, we may use tooth positioners, we may have time for settling, we have finishing aligners now too that we use, etc. Right? And so with clear aligners, we can't expect just to have a perfect outcome at the end, because we have to, again, take into account things that didn't happen with the appliance. So finishing elastics, I think, are very important. So for example, in this case, you can see there's a gap here at the occlusal where there wasn't really an attachment on that tooth during treatment. And so we run a vertical elastic and settle it in. One thing I would recommend you never do is that this patient has a posterior open bite. The aligner was cut here and elastics were run. And what ended up happening is that whole buccal segment dumped in. And now we have an anterior open bite because you lose control, right? So if you're going to run those elastics, please make sure, in my opinion, that aligner should stay intact. So the same patient, this is now the same patient at the end of refinement, still has a posterior open bite. But the aligners, if you look, they actually fit. So there's lag in the expression of leveling the curve of speed. So running the elastics helps to express the energy in the aligner to finish closing that posterior open bite, which is why elastics are important. Even if a patient's class 1, I still tell them they may need rubber bands to finish their case, because you don't want to surprise the patient with that. And so after 1 month, 1/8, 4-ounce elastics, that curve of speed levels and the open bite's closed. This is a patient that unfortunately was being mismanaged by a general dentist in the St. Louis area, and it was in a postural splint with braces for 5 years. And I saw her in the consultation. I said, I'm sorry to tell you this. You're on a road to nowhere. I recommend you get these braces off immediately and then come back in. We're going to give you a break and then get you back into treatment to fix all this stuff. And so this patient basically had her braces removed. We put her into a deprogramming splint because she was in an anterior posturing splint, so I didn't really know where her CR was. So we wanted to deprogram her first, gave her, I think it was about 5 months to recover from having the appliances on for so long, got her a good cleaning. Was hoping for some relapse to happen as well from having the appliances off. And then we wanted to re-diagnose the case, but go into clear aligners to finish the case off. And so I'm not sure how many of us would want to treat a posterior open bite with clear aligners, because that's what we're trying to avoid with clear aligners, right? So, but I just want to show you again that this is a controlled appliance, and that I don't take that as a limitation on what we need to do. She became very flared during her treatment mechanics, so we're also going to use IPR to normalize her incisal angulations. So this was the patient after deprogramming, and here is where we're going to start the case in terms of the submission to our clear aligner product here. So as we look here, we're getting relapse of the buccal segment. We have extrusion attachments in the posterior, IPR to help upright the incisors. And the question is, is this going to happen? And the answer is, I have no idea. So what do? We add button cutouts in the passive aligners at the end of treatment as a plan B, because I want to make sure I have a backup plan, right? So patient gets through the first set of trays here. You can see that we use the superposition tool to plan the amount of incisor retraction we're getting to normalize the incisal angulations. Refinement, where things are going pretty well. Now we're relapsing the 7s with regards to, we initially alleviated the contact off of them because she was only tripoding on the 7s, and end up finishing the case here for the patient. And so again, those elastics, I think, become a very important part of just making sure that we understand how to finish these cases with the same results and outcomes as what we want with fixed appliances, because we used elastics to finish our fixed appliances daily. So we have to treat the appliances the same. So considerations: when you have issues, please evaluate again the potential interferences, focus on leveling the curve of Spee, curve of Wilson, and making sure you address your arch coordination with rubber bands, especially the cusp-fossa relationships, as again, because expansion may not have happened to what you would predict in certain areas, you may have those interferences. Also, please consider that elastics may be an important part of finishing your cases, and also active retention. If you're not doing that in your practice already, I think it's just a nice practice management tip. It gets the patient happy, gives you some leeway to finish the case as the doctor, because I'm sure we're all perfectionists being in this room as orthodontists. Please take time to fill out the C for this course. I hope that you enjoyed it, and I want to thank you so much for your time and attention. I have 1 minute left for questions. Thank you. Thank you.
Thanks, Dr. Moshiri, for this informative presentation. Any questions for Dr. Moshiri?
Good. Cool.
Thanks for attending, everyone. This concludes our session.